You've decided you're ready to become a parent, and suddenly you're overwhelmed with people who feel they have the right to inform you on the correct way to conceive, give birth, what fears you should have, and the proper way to parent. How do you filter through the opinions? How do you know what's trustworthy information and what's a myth or just plain outdated? Welcome to the Birth Ease podcast. Join your host Michelle Smith and her guests as they cut through the noise and fear by sharing valuable tips, tools, and proven methods that help you connect with your own inner wisdom as you navigate the sacred journey that is pregnancy, birth, and parenthood in a more relaxed and confident manner. This podcast does not constitute, nor is it intended, as medical advice.
Hello, Birthies families. Welcome to this heartfelt space. I'm your host, Michelle Smith. And in the podcast, I have had the honor of interviewing midwives and giving them the space to share what's on their heart and on their minds. And in this episode, I am incredibly honored to have an OBGYN physician sharing what's on her heart and on her mind regarding what she would like families to know, and sharing what physicians face, the logistics, what can happen in the case of an emergency, and the importance of communication and that physician-patient relationship. I am just so honored that she was willing to share so candidly about her experience and those factors and barriers and logistics that physicians do face, and how that shapes the way that they can and do practice. In our conversation, we spoke for over 2 hours, so this episode will have a part 1 and a part 2. Now retired, Dr. Donna Ivery is a native of Cocoa, Florida. A Johns Hopkins University-trained biomedical engineer, she started her career at AT&T Bell Laboratories in New Jersey. The call to medical practice came, and she moved to Atlanta to attend Emory University School of Medicine. She completed her medical and gynecological training at Ivery in 1996 and is board certified in obstetrics and gynecology. She embarked on many years of travel practicing obstetrics and gynecology in Georgia, Hawaii, Oregon, and St. Croix, U.S. Virgin Islands, before returning to North Brevard, Florida in 2005, where she offered a full range of gynecological services. Dr. Ivery has delivered over 4,000 babies, performed over 2,000 surgeries, and provided over 50,000 women's health visits. Welcome, Dr. Ivery, to the Birth Ease podcast. I am so grateful that you are here with me today.
Michelle, thank you so much. I am very, very excited about being here. This is a rare opportunity, and I can't thank you enough for having me on your show.
Oh, you're very welcome. You're very welcome. So I'd like to start with what brought you to the field of obstetrics and gynecology?
As is true, most of my life, I have taken a fairly non-traditional approach. OBGYN and trauma surgery were the only two things that I liked when it came to medical school. And I had to make some decisions about which one to pursue. And when you looked at the beauty and the positivity of being in obstetrics and gynecology with healthy patients and very few deaths and very few bad outcomes versus trauma surgery,
Right.
where 50% of your patients are going to die and you're going to spend a lot of time going out telling families bad news, I decided to go with the OBGYN, and I don't regret it at all. It was a perfect decision for me.
Yeah, that makes sense. Yeah.
Mm-hmm.
It is such an amazing time in someone's life
Oh gosh, yes.
when they're bringing a child into the world. It really is. And most of the time it is very happy, but there are those times that it can turn stressful, or even
Mhm.
there can be emergencies. And that's part of what we wanted to discuss today,
Mhm.
is those times that maybe there's an intervention that's needed during the labor. And we wanted to just discuss with families what might be going on. As a doula, sometimes I feel like families can get kind of sideswiped if things become emergent.
Agreed. It's funny, as an OBGYN, one of the frustrations, especially when you are helping to care for a patient who is not your private patient. So when we take call,
Mm.
we take patients, we take all comers. And so, especially when you're working with families and working with patients who don't know you and you don't know them. And so the notion of them being prepared for what could happen, being prepared for the type of interventions that can happen, that does make it harder,
Yeah.
especially if there's an emergent situation that comes up.
Yeah.
I think the hardest issues are not the clear emergencies, but the urgencies, and how urgent are they, and what do they mean, and sometimes even the suspicion that it's kind of manufactured
Yeah. Yeah.
for somebody's convenience, because you've been hearing people talk about it anyway. Oh, well, she's probably going to have a C-section, long before anyone said anything to you or the situation was presented. So I know there's a lot of miscommunication. I think there's a lot of mistrust for various reasons, some of which is deserved. And I think that talking about how I try to prep my patients so that they understand the kind of things that can happen when I need to intervene has really been important. I felt like I had really, really great experiences and interactions on the private level, mainly because the opportunity to really teach my patients what my philosophy is about intervention and have them tell me what their desires are, what their concerns are, how they'd like their experience to go. I think that that has been a wonderful aspect of my career.
It's that relationship.
Yes.
It's
Yes.
creating the relationship. And you and I both know that makes such a difference in obstetrics and gynecology, but especially when someone's giving birth.
Mm-hmm.
And sometimes you can't always do that. And you can have a knack to create that relationship with someone pretty quickly, too. Some
Mm-hmm.
of us kind of have that knack.
Mm-hmm.
But it's communication and relationship makes such a huge difference. And I think the way that our medical system is going is we're getting away from that model of a pregnant person having maybe 2 or 3 physicians that could be on call instead of 10. So it's hard to form a relationship as well.
Oh, the system is even progressing beyond that as we see hospitals and the healthcare system in general
Mhm.
evolve, devolve, depending on the perspective, into a system whereby prenatal care and the person or practitioners or whomever is going to deliver your baby are not the same group.
Yeah.
Because with hospitalists,
Yes.
you have 12-hour shifts,
Yeah.
you have 24-hour shifts. So you don't have any idea which doctor is going to deliver you. And that doctor may not even be associated with the practice that you've had your prenatal care with. And so there are a lot of changes, and that certainly fuels this disconnect with the patient and the OBGYN with regard to trust.
That's a really good word. I like that. Disconnect.
Mm-hmm. Because nobody really wants to be in a situation where they are being cared for by people they don't trust. And at the same time, physicians don't want to have to take care of patients who innately don't trust them.
Right.
That's one of the bedrocks of the physician-patient relationship is trust.
Mm-hmm.
And the system doesn't foster that. And to the best of one's ability as a physician, I have to overcome that. And it's easy to do in my private practice because I have continuity and we have a long time to really kind of get to know each other.
Right.
When I was a hospitalist, it's a whole different ballgame. I mean, I literally have met a patient as she was getting rolled into the operating room for an emergency C-section.
Mm-hmm.
And I frankly did not even know her name before I did her C-section.
Mm-hmm.
And that's because everything was going on at shift change.
Yeah.
And as far as physicians are concerned, if there's an emergency, there is no shift change issue. Things have to keep going. And our shift changed at a different time than the nursing shift did.
Oh.
And of course it needed to, because you can't have both sets of providers changing shifts at the same time.
Yeah.
And I literally walked in the door to start my shift and was told, put your bag down and go to the OR.
Mm.
And I literally am standing in front of the operating room door as the patient is being rolled up from the emergency room. And I'm Dr. Ivery. I'm the doctor that's going to do your C-section. And that's the only communication we had. And to be honest, it was 3 days after that before we actually met.
Mm-hmm.
And so the majority of people don't see the near death and life-threatening side of obstetrics. And as a physician, I've definitely seen it. And so how do we communicate what happens under those circumstances? Most patients aren't worried that you see a situation that's life-threatening for them or their baby and act emergently and rapidly. They still want to understand what happened after the fact, but they're going to give you a pass on that. It's when you see things going on that need intervention, and then all of a sudden this urgent intervention takes 6 hours.
Mm-hmm.
And so what are the things going on when it comes to that? So I think the notion of a disconnect and a breakdown in trust really kind of fuel a lot of all of our dissatisfaction with how the system is going.
Right.
Yes. So one of the things I do with my patients in the private practice setting, and I say private practice only because that's our continuity, I was always quick to talk about at the beginning of the prenatal cycle, not at 32 weeks and 34 weeks, at 12 weeks is when I start talking about my philosophies on labor and delivery and how I approach it. I personally am a physician that insists that an IV be in. The majority of time, we don't even need to use it. And I would tell my patients, I need an IV to be in. We don't even have to use it, because as long as things are fine, I don't really restrict your ability to drink liquids and to stay hydrated and things like that during labor. But if something is going on, if something happens, the difference between brain damage and not having brain damage for your baby is a matter of minutes. And I tell you, you don't want a minute being taken up trying to get an IV in your arm if that's what's holding us up from getting your baby delivered safely.
Right. Right. So just placing like an IV lock, a HEP lock,
Mm-hmm.
right? And not having to have fluids. Yeah. Yeah.
Absolutely.
Yeah.
Absolutely.
Yeah. Because we both know it can.
It turns on a dime.
It can. And birth, I feel like, is a normal, natural
Mm-hmm.
process. But
it is.
And I feel like it's best if we just step back and allow the birth to happen. But if we need to step in, it's good to have things in place to be able to do it.
Absolutely. And that's always the philosophy I had, is that 80% of the time, my level of training is not needed. I was never under the illusion that pregnancy and delivery were diseases or operative procedures. And I never take that approach. And there are plenty of physicians who do. And so I do understand that many women have had a very different experience than I've tried to make sure doesn't happen in my sphere of influence. So I do my best not to discount anyone's experience outside of what I've ever seen, because there is nothing you can tell me that I would not believe, good or bad, about an experience in medicine.
Mm-hmm.
And that's unfortunate. But I've seen colleagues do horrendous things, and they don't have that philosophy. And so my sphere of influence is only what it is. I think that's part of why, as I'm changing what I'm doing in my career, I want to get more messages out about what's really happening, how to be prepared, and really have a feel of knowing what's going on. So an IV is one of them. And one of the things I tell people, hold your breath. I want to see how long you can hold your breath. I mean, really time how long you can hold your breath beyond that urge to breathe. Keep going. Keep going until you almost feel like you're going to pass out. And then I want you to time how long that took. And then I want you to double that. And however many minutes that was, that's about the capacity of an infant in transition from pregnancy to life can go without oxygen.
Mm-hmm.
And they go without oxygen when the umbilical cord clamps off. So when the umbilical cord is obstructed, or for some reason there's no blood flow to the placenta from the mom's side, that's when the baby starts holding its breath.
Mm-hmm.
And so when we talk about fetal monitoring, having a certain type of deceleration indicates to us the degree to which the baby is struggling to get adequate oxygenation.
Mm-hmm.
And brief episodes here and there are not as worrisome as persistent episodes.
Yeah, or those prolonged ones, because we all know the sound. You know the sound of when a baby's heart rate is going down. And it's replaying in my mind those times where a baby's heart rate goes down and it's not recovering well. And that's where things can and do become urgent.
Yes.
And you expect a certain amount of their heart rate to go down when you're pushing, because they're getting that head compression. But prolonged low decels.
And then over time, looking at your monitor and not seeing the baby recover to a normal spot, a normal behavior.
Right.
After a set of decels is when it starts to get worrisome. And there's a lot of gray area in terms of when you call the shot in terms of it's time for a C-section. There's a lot of gray area about that. If you take humans, we all have different capacities as physicians, as OBGYNs. We all have different tolerances for risk. We all have different tolerances for things not being normal. And that's one place you see the variance.
Yes.
The other place you see the variance are the things that you don't know behind the scenes. When I trained, it was a large inner city hospital. We did the second or third highest numbers of deliveries in the country. So we were very, very, very busy, very, very, very large, very, very team oriented. And I remember the nurses reminding me, when you leave here, you're going to miss us when it comes time to how quickly you can go from something being emergent in the labor room to having a baby out alive and crying and safe. And they weren't kidding, because ultimately in my training program, from the point in time that I made a decision to do an emergency C-section, in general, we had a baby out in 10 minutes. Out in 10 minutes. From the labor room disconnecting everything, going down the hall, getting in the operating room, getting them appropriate anesthesia, getting everybody there, getting ready, doing the C-section, having that baby out. We could really achieve that in like 10 minutes.
Wow.
That does not happen in the majority of hospitals. So if you're in a hospital where the anesthesiologist is at home, I've also delivered babies in rural communities. I delivered babies in a hospital in rural Georgia where the anesthesiologist lived 45 minutes away.
45 minutes?
Yes, 45 minutes away. The OR nurse lived 30 minutes away. And the only way I found that out was because I happened to be passing the operating room around 5 o'clock, and I saw her putting a padlock on the operating room door. And I was horrified. Now, I'm fresh out of residency, so I'm used to literally there being everybody there at my fingertips at all times. Everybody needed for a C-section. There, at the moment that a C-section is called, we have a baby out in 10 minutes, kind of thing. And then a year later, I'm in a situation where I'm in a small rural hospital, and they are putting a padlock on the one operating room we do have. And so I questioned her, I said, why are you locking it up? She said, well, we're going home for the night. I said, but what happens if I have a stat C-section? And she had no idea what I was even talking about. She's like, what are you talking about? I said, a stat C-section. She was like, what is that? I said, an emergency C-section. She said, I'm your nurse, don't worry. I said, yes, but if the anesthesia is here and I've got one other personnel, I can get going. She said, anesthesia lives 15 minutes further out than I do. And I'm the one that gets the phone call. She said, so there's no operating until I get here. And by the time I have the room open and ready to go, anesthesia should be coming through the door. And so the lack of understanding about logistics really contributes to the sense in a lot of patients' minds that this was a joke. It wasn't quite time. It wasn't really necessary. And sometimes if you know the limitations of your facility, you're going to call things earlier than you would call it if you had a facility where things could go rapidly.
That was going to be my question, that must really influence when you decide that a cesarean birth would be necessary. You can't wait it out to see in the same way, because if it does turn and nobody's there. Oh my gosh.
And let me tell you.
I'm just sitting with that.
Oh, I can tell you stories. It took a minute to transition from being a cowboy that I can take people to the very edge to understanding that the cavalry is 2 hours out. There's a difference.
Yes.
And your management is different. So you don't let a patient and a baby go to the edge if you can't snatch them back fast enough.
Right.
And so there's a lot of that. When you talk about hospitalist work and the fact that the doctors will change shifts, well, we all will naturally want to not have ourselves caught in the middle of something you can't walk away from when it's time to go home, quote unquote. And that's just human behavior. But it's interesting that a good friend of mine just recently started doing hospitalist work. And she told me about a story recently that happened to her where a patient literally in a fairly urgent situation, it took 3 hours to get that patient into the operating room for the C-section. And she was ready. The nursing staff in the room were ready, but the operating room wasn't available. There was one anesthesiologist and there was a trauma in the main operating room.
Yeah.
And so they can't stop the patient that they're taking care of to come start a new patient because there are not enough people. And so those are the kind of logistics you also look at If somebody has a ruptured aortic aneurysm and there are trauma downstairs in a hospital at 2:00 in the morning where there's only one available crew and they're already busy, then you have to find the next crew or wait.
Yeah, or they have anesthesiologists on call if they have more than one, but you have to wait for them to come in. Is that right?
Oh, no, somebody's on call.
Right.
And the on-call person's already there.
Oh, they're already there. Okay.
They're already there.
Okay.
Yes, they're already there. And so now you've got to find somebody else to come in.
Somebody else. Okay.
And let me tell you, disasters happen in those kind of delays.
Yeah.
Yes.
Yeah. I'm thinking of our women and babies hospital here in Orlando, and it's women and babies. So there's always an anesthesiologist, more than one.
Right.
Nurse anesthetist.
Right. And I trained in a hospital that functioned like that. And you better believe the first time I worked in a hospital that was a rural hospital, I was astounded. I've worked on hospitals that are on islands. So now imagine that. One hospital on the island. Obviously, it's not going to be a hospital that can handle a lot of high-risk behaviors. And I had a patient who was 27 weeks, and she came in contracting with horrible abdominal pain, and she ended up being somebody with an active appendicitis at 27 weeks. And there was no way she could be airlifted off of the island
to Miami
because she was unstable. So I had to take her to the operating room with the general surgeon. And this is a hospital that has 3 labor and delivery rooms and 4 operating rooms total, but only one can be used after hours. And then a second one, if there's an emergency, can be opened up, but it's hard to find enough staff to run 2 cases after hours. And after hours is after 5 p.m. on the weekdays and anytime on the weekends. And understand the anesthesiologist is not an OB anesthesiologist. This is a general anesthesiologist, and they are not happy dealing with preterm patients. They don't like dealing with babies because that's not their level of expertise.
Right.
So all of these things come into play. And knowing what hospital you're in and what your hospital services are in an emergency is important too. So we go forward and we're wheeling that patient back to the operating room. And a patient comes in emergent who had been trying to deliver at home. And this is not a negative against trying to deliver at home by any means. This is simply talking about knowing the capacity of one's hospital. She had a baby that just was too big to come out. And thank God the baby was doing fine. But she had been home laboring 3 or 4 days and came in exhausted. Oh yeah.
That's a whole other conversation.
Oh yeah. That's a whole other conversation. And she and her husband were literally expecting that when they hit the hospital, they would be relieved of their suffering immediately. And under other circumstances, that is likely to have been the case. But on that particular day, there was someone more emergent than her, and there was not the capacity to deal with 2 emergencies at the same time. And thank God, her baby was essentially a healthy baby. Now, it was as exhausted and dehydrated as she was. And so I assessed her strip. I was able to tell her, and the funny part about it, she was my private patient too. So she already knew me. And I was basically able to tell her, look, I've got to take somebody else to the operating room right now. I can't take you. And the look on her face is just like, oh my God, this is hell. I've died and gone to hell. I mean, she could not process that this wasn't about to be over immediately.
Right.
And I gave her some Demerol. Actually, we gave her morphine because Demerol lasts too long. Gave her some morphine. We gave her plenty of sugar-containing IV fluids for her and that baby. Gave her some oxygen. And I made sure she had a high enough dose to rest. She needed the rest, the baby needed the rest, and the reality was they were going to have to wait. And so I got all that stuff set up and ordered for her, and then I went and did the surgery on the other patient. And we did the surgery on the other patient, and it wasn't particularly complicated, but it's not fun taking out an appendix on a 27-week pregnant patient with a general surgeon in a setting where we don't have maternal fetal medicine or an OB ICU or anything.
Right, right.
And she was actively contracting. She came in contracting.
Wow.
And so after the surgery, I still have to manage that she doesn't deliver and that she gets settled down and that that baby is still safe and safely in, and finally get her stabilized to the point where we could then transfer her to a hospital that could handle it if she got into labor and really was in a position to deliver. And that's what ended up happening. So the patient that came in with the baby that was too big to come out eventually had her C-section 5 hours after she got there. She was fine, the baby was fine, and I tell everybody, by the grace of God, all of those things were fine. But it was a lack of resources. It was not an intention to harm or punish. It was the reality of what was happening. And there was no time for me to explain in detail what was going on for her. I had to just let her know. You're going to have to wait. Somebody's sicker than you, and this is what we're going to do. And so then postpartum, literally the second day postpartum, because she still needed to rest that first 24 hours because she was so exhausted.
I'm sure.
And then we were able to sit down and have a long talk and have a long conversation about what happened. So just imagine if she and I did not know each other and that had been the situation. It would have been a whole different set of emotions and the notion of trust and, to some degree, the notion of anger on the part of the physician, that how could you possibly be pushing for 3 days and in labor for 3 days? I think she had been pushing like 8 hours, but she had been in hard. Let me tell you. Yes. And so when we talk about educating patients, and that's one of the things I told her, I said, if you had told me that you wanted to have a home birth and that was your plan, I could have at least given you parameters to understand where normal and routine and safe end and where intervention probably needs to start being addressed. And there are multiple times where that could have been addressed, especially since at 36 weeks, you were already measuring out at 45 centimeters.
Oh my gosh.
Yes. I said, I could have told you that baby wasn't coming out because it's too big. But we never had a chance to have that discussion. And for you to have ruptured, she had been ruptured 72 plus hours when she got there. That's how she went in labor. She ruptured. That baby didn't have a fever. That baby was flat on the monitor, but there were no D cells. She was still contracting. And she's the most exhausted patient the most exhausted human I have ever seen in my entire career, before or since. And we were fine, but I was just so rocked that she didn't know what normal parameters were like. And I think that's part of it too.
Yeah. So can you name some of those parameters that families would want to look for?
Yes. So when we talk about, and you and I had mentioned some things earlier, the assessment of how low in the pelvis a baby's head is. With the first full-term delivery, the natural processes are for the baby's head to get really, really low in the pelvis. And low in the pelvis translates to closer to the outside of the vagina. So how close to the outside is the head already getting? And indications that of size discrepancies and things like that when a patient has never had a baby. start when the head is not coming down in the pelvis to start to push the cervix to thin out, because the contractions are not what thins out the cervix as much as that head coming down the first time you have a delivery.
Mm.
After you've had a delivery, how low the head is in the pelvis isn't such a factor when we think about, is it possible that the baby's size is an issue for this pelvis? So that's one set of parameters that can start being looked at when a patient's getting checked in the office, or getting checked after 36 weeks and getting checked at 37 weeks and getting checked at 38 weeks. How low down is that head? In the patient who's never had a delivery at 39 weeks and the head is not at least at zero station, there's a big concern there. If someone has had 3 or 4 babies and the head is not at zero station, it does not faze me whatsoever, ever. Because if the patient's not in labor,
Right.
that baby can be doing all kinds of things.
Right.
So,
and a few good contractions can bring a baby down. A cervix can open. Yeah.
A few good laughs.
Yeah.
Get them sneezing, you know.
Yeah. Yeah.
So that's one set of parameters we look at.
So I have a question, because a lot of mamas at first-time moms, especially at 40, 41 weeks, a lot of times their baby, when they enter into labor, is at -1 station versus 0.
Mm-hmm.
You know, when mamas tell me the station the baby's at.
Mm-hmm.
So I've found that, especially if a mom is getting closer to 41 weeks and it's a first-time mom and the baby is still -3 station, way up there in the pelvis, and it's a big baby, to me, that's a sign that we've got something going on. So I'm just asking, because a lot of times I've heard from my mamas that they're more like -1 station versus 0 towards the end of their pregnancy. So I just wanted some clarification. That's all.
It's very subjective.
Yeah.
In the sense of my 0 might be somebody else's -1.
Right.
And so there's that. But the 0 is the most narrow part of the pelvic opening.
Mm.
And if the head is not already fitting down into that space and pushing against the cervix, and we know it's doing that because the cervix is getting thinner and thinner. So there's no dilation, but there's effacement going on.
Mm-hmm. Mm.
If that's not happening, especially in a patient that's never had a delivery, that is not a good sign with regard to the baby's ability to fit into the pelvis, because that type of maneuvering happens without labor occurring. And so when we see a -1 station, but that head is pushing on the cervix and the cervix is effacing, that's fine. That's not necessarily a red flag.
That makes sense.
But if we don't have any effacement and the patient's baby's head is floating, you go to check the patient and the patient is closed and thick and the head easily moves back out of the pelvis and you're at 39 weeks, that's a worrisome sign. And we say 39 weeks because the majority of people, the majority of women, will deliver between 38 and 42 weeks. But after 41 weeks, the rate of spontaneous fetal death increases. And I can tell you that the hardest thing I have ever had to do in my career, and I've had to do it multiple times, is to look a patient in her face at term who thought she had been feeling her baby moving. And what she had been feeling is her dead baby floating in her belly and telling them that her baby's dead.
Yeah. Yeah.
With no warning.
Yeah.
No warning.
It is.
And so that's why physicians are crazy when somebody wants to go past 41 weeks. It's not often that we deal with dead babies, but OBGYNs can tell you about dead babies. And nobody wants to live through that.
No, that's the other side of my work is grief support to families that have experienced perinatal loss. And it's just so, it's so difficult.
It's soul shattering.
Shattering is a perfect word.
Oh, yeah. And I can tell you the 5 patients that I remember clearly, some of whom I delivered and had this experience with them 20 years ago. And I can still see their faces. And I can see their babies. And a lot of times that drives the conversation as an obstetrician because it's difficult to convince practitioners who do not have the experience of dealing with fetal deaths that that concern is real. And the numbers aren't high. They're too high for our level of resources in our society. Don't get me wrong, that our maternal mortality and fetal mortality rates are way too high.
Right.
But are the numbers crazy? No, they're not crazy. But who wants to be that one? Who wants to be those 10? Who wants to be the person that is in that, who got the short straw? And what do we do to keep everybody from getting the short straw? And that's really where a lot of the disagreement becomes about how do we eliminate the short straws when it comes to pregnancy and childbirth without eliminating the beauty of it.
Right.
Without destroying the spirituality of it.
Right.
Because nothing beats holding a life in your hands when it takes its first breath. I like to be on that end of life's transitions. I do not like to be on the other.
Right.
And I've seen the other end as well.
Right.
I've held a baby that looked like I could just blow into her mouth and make her breathe because nothing was wrong with her, except she had died a couple of hours before her mom got to the hospital. I mean, those kind of things just are soul shattering. And so how to avoid having those things happen, and yet how to avoid getting a C-section because the doctor wanted to go play golf.
Right.
How do you avoid? All those things come into play. And certainly we have to figure out how do we bridge those gaps so that we have trust, so that patients feel comfortable and knowledgeable to know that they're in safe situations and to know that what can happen can get handled well and that they won't pay the price and their babies won't pay the price.
Right. And I think too, having conversations with your physician and having a physician that is supportive of how you want to give birth.
Oh, yeah.
That's invaluable. Because if you have a physician that feels that inducing at 39 weeks is the safest route for you and your baby, but you want a natural birth and you feel comfortable as long as you're okay and baby is okay, going to maybe 41 weeks in 4 days or 41 weeks in 5 days, and you're willing, you understand the pros and the cons, then being able to have that relationship where everyone is honored and it's a relationship and working together. But, talking with you, and I understood this before too, but especially in our conversation, that there's a risk on the physician and they're coming from that lens too, because everything ultimately falls on the physician.
Oh, it does. I mean, and it's a trend. I won't say a transition as much as an evolution as a physician, because I've had a patient who insisted on allowing labor to start whenever it was going to naturally start. And she was low risk. She was as low risk as they come. And she was past 41 weeks. And I had started talking to her at 39 weeks about how these things progress. She wasn't really dilating. She wasn't effacing. And she refused to come in for monitoring.
Oh.
And refused sounds like a horrible word, but I mean, she declined to come in for monitoring. And we called her and whatnot, and she just didn't come. I mean, because that's what happens. People just don't. Sometimes you don't argue, you just don't do.
Mm-hmm.
And we tried to track her down. So, of course, she wasn't returning our phone calls because she knows she was supposed to be there for monitoring. And the next day, we managed to catch up with her. And she was like, oh, I'll be okay. And I'll come in tomorrow. I want to rest today because I got into a little fender bender this morning at the grocery store. And she didn't come in about that. And she did go in to labor and delivery the next day about 11 o'clock because she felt like she was in labor. And she was in early labor. And we got on the monitor. And the worst call, let me tell you, when she got in the bed and the nurses went in there to put her on the monitor and everything, and the nurse comes out and said, Doc, I need you to come in here. I said, don't tell me that because I know what that means. I know what that means. So I already know what it means when I walk through the door that you don't even know what's about to happen. You don't even know what I'm about to say. And it's going to be the hardest experience of your life. And one of the things that they had said in the office about not coming in, because I fussed at her, when we caught up with her the day after she missed coming to the office to get monitored, she was just like, Dr. Ivery, it'll be fine. You know, it's God's will. It'll be fine. And she said those words. And when the nurse came out to me, she's like, Doc, you need to come in here. I said, don't tell me that.
I'm feeling this in my gut. I'm sorry.
Yes. And I just looked at it. She said, you need to come in there because they couldn't find the heart tones. And I have to come in there with the ultrasound machine. And so I bring the ultrasound machine to the door and then I go in and try to find the heart rate, and I can't find the heart rate. So I bring in the ultrasound machine, and that's when the family really understands that something's not right. And they're like, what's going on? I said, I'm using the ultrasound machine to see if we can locate the baby's heartbeat because they aren't able to locate it on the monitor. And then the room gets quiet, but nobody really worries because the next thing the mom says is, I was fine because I've been feeling her move. And she's not making that up. This is a full-term 7-pound baby floating in water. Yes, she's going to feel movement because the baby is floating around. And so sure enough, I get the ultrasound machine and there is no fetal cardiac activity. And there's no way to sugarcoat that. And when I'm staring at the screen with a flat face, they're getting quiet and they're like, what's going on? I said, your baby's heart is not moving and your baby has died, because nothing gets heard after that.
Right.
And I don't ever want to say those words. And I'll be honest, now that I'm retired, I'm so thankful I will never have to say those words again.
Yeah, I can feel that. I'm teary as you're talking because, like I said, this is the other side of my work. And I've been in the room when the physician has to say that. And
yes.
Yeah.
Because it's not like I can go and not have to deal with it anymore, because we still have a baby to get out and we still have a mama to keep alive. And we need a mama that we haven't damaged her reproductive ability so that if she so desires, she can have another baby. And we also have to have a mom that can somehow recover from this experience and continue to move forward in life. And all those things have to occur. And we still have no explanation for why the baby died. And so I explain to them and I tell them and whatnot, and we get everything going. And, you know, they're screaming and hollering because there's disbelief, because she felt the baby moving. She came in because she was in labor and she felt the baby moving. So there's a level of disbelief there that just doesn't get broken until you hand her a dead baby.
Yeah. Yeah. That's just the way our human psyche works. Yeah.
Yeah. And so what are the odds that that would have happened to them? Low, but she was the one that got the short stick. And so How many patients do you think after that I was cooperative and letting them go 41 weeks?
Mm-hmm.
Because one of the things that happened was after it was all said and done, her husband comes out and I'm after the delivery and everything. Because when I tell you that baby looks like she had been moving 2 hours ago,
Mm-hmm.
she was perfect. She just looked pale. That's it.
Mm-hmm.
Nothing wrong, just looked pale. The placenta didn't look particularly bad. I mean, it just, again, the cord wasn't around her neck. None of that. And so once we delivered her and everything, then I went to my little crying space because people don't understand that as a physician, I have a crying space.
Mm-hmm.
I cry, but I don't cry in front of you because that's not what you're there for. That's not what you come to me for. Doesn't mean I don't cry. And so I had come back to the nurse's station, start working on some paperwork and whatnot after leaving my crying space and having my doctor face back on. And her husband comes out and he's like, why did this happen? And like I had something to do with it.
Mm-hmm.
And all I could tell him was, it's God's will. Because that's the best I could tell him, other than y'all had the chance to not be in this position. I could have kept you from being in this position, not me being God. I'm not saying that at all. I don't want anybody to ever think that I think that I am God. I do not. I don't think any part of that. I don't think I'm an instrument of God. I do the best that I can do in all circumstances. But sometimes you can't be in a situation where a patient has a great outcome. And sometimes that's because of the decisions that the patient made.
Right. To get in a car accident and not come in, to refuse fetal monitoring, to check on the baby. I'm not trying to blame. I'm not trying to blame, but I understand what you're saying about those decisions. Because even my clients that choose home birth or birth center birth, you go in for a biophysical profile to check on the baby, to make sure the baby's okay. And if the baby's not scoring what we want the baby to score, then you transfer to the hospital. So there's not a situation like this.
Right. But fetal monitoring is not part of natural birth.
Oh, it is with the ones that I work with.
Oh, absolutely. Yeah. But I'm just saying, you see how that gets turned around.
Oh, I do.
Yeah. So that's not me excoriating you guys. It's that there's still going to be a segment that are just like, well, that's not natural.
Right.
I shouldn't have to. I can feel my baby move. And if my baby's not moving right, then I'll come in.
Mm-hmm.
And it goes back down to trust and a disconnect. Mm-hmm. And there is nothing more beautiful than natural labor and delivery.
Right.
Let me tell you.
Yeah.
Let me tell you. You got a bright, happy baby right there in his mom's arms. You got a mom that's engaged and right there. You got the family there. Let me tell you, there is just nothing better than that. Mm-hmm. But death is natural too. Mm-hmm. And I can promise you that is a soul-shattering experience in the labor room as well.
It is.
So.
It is. And sometimes you can do everything right. You can do everything right. And it's unexplained.
Absolutely. Oh my God. I had a patient that had 2 term losses. Unexplained. After having 2 babies, after having 2 normal deliveries. And when I tell you the hardest pregnancy I ever helped a patient go through was her 5th pregnancy after those 2 term losses.
Yeah.
And even until that baby was like 3 months old, she was having a hard time bonding because she was having a hard time believing that baby was going to be a keeper.
Yes.
That the baby was going to stay, as we say.
Yeah.
And so we went through a lot. We went through so much. And I induced her at 38 weeks.
And I think that's appropriate. Very much so. Yeah.
But there are those who I had to explained my actions to for inducing her at 38 weeks.
Mm-hmm.
And when it comes to physicians, I hate to say it, but the reality is malpractice liability.
Mm-hmm.
That patient that I talked about who had the car accident and things like that, they could have sued me, and that lawsuit would have gone through, and I likely would have had to defend myself. And I probably would have won 3 or 4 years later, having had literally every word in the entire medical record and my office and the hospital scrutinized for a mistake, having nothing to do with what happened. So let's say my staff doesn't document that they talked to her the day after she didn't come in for her NST.
Oh, yeah.
And she turned around and had this outcome.
Mm-hmm.
That would have been difficult to defend because if it wasn't written, it didn't happen.
Right.
And so the argument could be in a patient who is going to sue. And sometimes the patient's not the one that's pushing the lawsuit. It's the helpless family members who want something done because now they don't have that baby in their life.
Mm-hmm.
There's all kinds of situations, but liability concerns also play into what happens with physicians. And I think most people would talk about more experienced physicians being less willing to compromise. And some of that has to do with having been sued over things that were out of their control.
Mm-hmm.
Because you can be sued. Nowadays with malpractice reform, attorneys don't take the case because they think they're going to win. They take the case because they think they can get you to settle.
Mm.
And that's a whole different ballgame. And there is nothing worse than having a bad outcome and then being sued. No, I lie. There is something worse than having a bad outcome and being sued. That you get sued by an angry patient, even though they didn't really have a bad outcome. They may have had a complication, but they didn't have a bad outcome. A physician that has been sued by a patient under those kind of circumstances will forever be a different physician.
Mm-hmm.
And that's something that the system has to address as well.
Yeah.
Because it's difficult. Because again, that issue of trust comes into play.
Right.
Communication comes into play.
Yeah. Well, and it's difficult too, because as you're talking and as we've gotten to know each other, like you sound like you are very supportive of natural birth. You know, I can sit and look through my magazine and then, I'll just come catch the baby when it's time, right? If the labor is all going well and the mama wants to go natural, and you are providing the space for the woman to do that, which for some women is so, so important.
Yes.
And not all physicians do that.
Agreed. Yes. Agreed.
And that's where it gets sticky. And then so I could be in a practice as a expecting mama, and I could bond with you and just go, Dr. Ivery is so supportive. She's just going to read her magazine and let me labor. And she's there, but reading the magazine is kind of like sitting on your hands unless you need to step in. But then if you're not there because you're not on call, and we get I'm just going to say Dr. X, who doesn't practice like you do, that is where that trust and that sense of safety gets destroyed, I think.
It is.
Because she's expecting a certain kind of labor, and that, she said I can drink in labor and I just need the IV lock and I'm going to have freedom of movement, and then another physician's on call and the whole thing
falls apart,
collapses.
Absolutely. And then if there's something that happens that can be something to be sued about, then everybody gets caught in that. But it's not even about that. It's about that's some of why there's so many inductions.
Mm-hmm. Mm-hmm.
Believe it or not, I probably induced about 70% of my patients, because then I could control that I'm there to help their experience.
Mm.
I can't control the colleagues that are on call. And the reality is, over my experience and over the years and over the places I practice, I've had plenty of colleagues that I would want my dog to come into labor and have them deliver. But I can only control what I can control.
Right.
Now, I'm not going to take somebody at 39 weeks who's on her first baby and -1 and closed and thick and start talking about an induction, because that's not an inducible labor.
Thank you.
That's you know, that's not an elective induction candidate. That's the right way for me to say that.
Right.
But
Right.
if you are already 2 centimeters and 80% at 37 and a half weeks, I'm probably stripping some membranes to help you get into labor and making sure that I'm around on the weekend and this and that and the other, because there's nothing that prevents me from coming in on my days off. If I'm not on call, there's nothing to prevent me from coming in for my own patient. I decide if I've signed out my own patient.
Mm.
But there's also the notion of balance in life.
Mm-hmm.
And so I have to decide, what is the volume of delivery work that does not make me feel like this is a burden as a career.
Yeah, because it's hard to be on call 24/7.
It is.
It is hard. And it's so hard.
And if you have a family, it's hard. That wasn't a big issue until I got married and had a child.
Mm-hmm.
It was a whole different ballgame when I was single, because I could care less.
Mm-hmm.
I could drop what I was doing. I remember being in a dinner party at my house, and everybody knew the rules in terms of my close friends and whatnot. If I run out of the house and I don't come back, somebody lock up.
Yeah.
When it's all done.
Yeah.
And I've had dinner parties or get-togethers at my house and been called in for a delivery and gone and done the delivery and come back and just resumed the party. It's not a big deal. My parties aren't drinking parties, so that's never been an issue. But it was not a challenge to my lifestyle before I got married and had a child.
Mm-hmm.
And then being a solo OBGYN doing 18 deliveries a month on my own was a big deal.
Yeah, it is.
And so I had to make some decisions. And we had a nice balance with regard to induction and things like that. And I used to induce at 38 weeks, and it took me a little time to come around to that's really too early. Hell, I used to induce at 37 weeks, and it took me a little time to come around that's just too early. And there's no advantage to the baby, and there is harm to the baby to do that electively. And after 39 weeks, an elective induction in a patient that has a favorable cervix,
Mm-hmm.
a Bishop score of 8 or more,
Mm-hmm.
rarely ends up in a section,
right,
or failed induction. And so you game the system in terms of making the likelihood of success higher
mm-hmm.
by doing it the right way. I was trained to use forceps, and I stopped using forceps very early in my career, simply because you just don't get the volume to be good at it, stay good at it.
Mm-hmm.
And I think they should be banned. And I think they should be banned because everybody has the ability to do a C-section on some level. And I hate to say it because it scares people, but you can very safely do a C-section under local anesthesia. I've done a couple. If you don't have to go truly emergently, then it can be done and the patient be comfortable as well.
Mm-hmm.
And so I see no need for forceps to remain in use unless it's used by somebody who uses them all the time in the appropriate circumstances. And that's exceedingly rare.
Yeah. I haven't seen forceps used in, my gosh, so long in my career.
Yeah.
And it is safer. My older daughter was born with forceps. And now looking back,
Mm-hmm.
and being in this career, because she's just turned 34,
Mm-hmm.
I understand whereas cesarean may have been safer and better for both of us in that circumstance. But I feel like 34 years ago, you know, forceps were so common. They were just so common. They were just used a lot. Is the way, and that was just how people practiced. And
right, but once vacuums came around,
right,
and vacuum technology matured, the usage of forceps is so rare. Now it's funny, forceps can be used during C-sections, and that can allow you to make a smaller incision or whatnot. But you need time, the luxury of time to do those kind of things.
Right.
And if you have time, 9 times out of 10, you can do something else. So as much as my old professors are turning over in their graves, I think that forceps are outmoded technology.
Yeah.
Yeah.
I think I've heard of someone having them done recently. When I had my baby, I feel like she was really, really still very high.
I'm sure she was,
and not down low where it would be better.
But that's the beauty. That's what forceps can do. And not, don't get me wrong. I used to turn a mean forceps now. Simpson and Elliott forceps, please, and a low extraction, smooth as silk. But I can get the same effect with a vacuum without the increased risk to the patient, especially the mom. Especially the mom. Fetal injuries with a forceps is somebody who doesn't know what they're doing. It's the damage to the mother's vagina and perineum.
Yes, ma'am.
That are of concern with forceps.
Yes, ma'am.
Yes.
Yeah, I think I had fourth degree. I think I had a fourth degree too.
Yeah, nobody wants a fourth degree. Nobody wants a fourth degree.
Yeah.
It's, so it's a lot to be. I was delivered with forceps. I actually have a scar on my face from birth because of forceps. That was back in the day where you got knocked out with Demerol. My mother always jokes that if I didn't look exactly like my dad, she would not know that I was her child. She said I could be anybody's child, but she has no recollection whatsoever of the delivery because she was just so drugged out. Those days need to be gone to the best of our ability.
Yeah. And they don't even use a vacuum much anymore. I feel like when I started my career, they were the new tool.
Oh, yeah.
And they were using it all the time. And now it's rare that I see a vacuum used.
Wow.
But the problem, I think, for mamas is it's so difficult to VBAC these days.
Available. Yeah.
It's getting better than it was 10 years ago, but mamas can feel so devastated when they have a cesarean birth because it is so difficult to have a vaginal birth after cesarean. They feel like they have lost that ability with that first cesarean birth.
Oh,
does that make sense?
It makes perfect sense. I get that. And that's a real honest concern, and it is a real honest issue. And yet, let's talk about the factors there.
Thank you so much for listening. And you can hear the rest of our conversation in the following episode. Dr. Ivery will discuss being a VBAC-friendly provider and the limitations and logistics that can happen within that. And we will delve deeper into patient autonomy, informed consent, obstetrical abuse, maternal mortality, and other difficulties that OBGYNs can face. Dr. Ivery will also be sharing the important projects that she is up to now. And so I do hope that you will listen in and enjoy the conversation between Dr. Ivery and I as much as I have.
For more great conversations like these, or to find out more information and access Michelle's library of amazing guests, go to birtheaseservices.com/podcast. For more information on the Birth Ease method, Michelle's classes, meditations, and other services, go to birtheaseservices.com.